Is this audible? Good evening, everyone, respected chairpersons and guests and colleagues. First of all, I would like to thank Dr. Ashish sir for providing me with the opportunity. So today I'll be talking about total knee replacement in tibia fractures. So straight away, in tibia fractures, we use long stems, which comes with total knee replacement, and it provides a single solution for stress fracture and knee replacement. As it's an intramedullary device, so you get early mobilization, and there is additional advantage of we prevent second surgery. There is less scar, and there is of course less operative time. So indications, first of all, old age patients who are arthritic, long-standing knee pain, malunited tibia fractures or acute intraarticular fractures or stress fractures of proximal third of tibia, which we commonly get. So this is routine medial parapatellar approach, bone cuts and soft tissue balancing, tibial stress fracture reduced under fluoroscopic guidance. After placing the tibial tray, we see the entry point for tibia, and accordingly we serially ream with the hand reamer. The length of stem is seen under fluoroscopic guidance so that we bypass the fracture by a safe distance. And then the stem is attached to the tibial plate, and other is routine. And we allow for immediate on the second day knee bending and partial weight bearing. And at 3 weeks, we allow full weight bearing. So this is the first case. She's a 72-year-old female, came with us with knee pain and minimal swelling, came on wheelchair. Weight bearing was painful. There was no obvious swelling. There was tenderness over medial condyle. This was the X-ray, which almost looks inconclusive. We got a CT done, and you can see on the coronal and sagittal sections, there is medial condyle depressed fracture. So this is the intra-op image. You can see the defect over the medial condyle. So we, of course, went ahead with total knee replacement in this case, as she was an age-old lady and with a varus deformity. We bone grafted with the femoral condyle bone graft, which we cut during the TKR. And this is the intra-op range of movement and the mid-flexion stability. And again, we used here a long stem to distribute the load. And of course, the bone grafting was done. A K-wire was left inside to keep the bone graft in situ. And this is at 2 months. This is the arm of the patient. The right limb has been operated, and she is walking comfortably, and a respectable range of movement has been achieved here. This is another case of a malunited tibia condyle. He was a young male. He was a teacher by profession, managed conservatively elsewhere. Patient had an arthritic knee with almost deformed tibia condyle. Knee was fixed in 15 degree of flexion, and there was nil movement at the knee joint. So it was almost 8 to 9 months old. So again, in this case, we did a total knee replacement. The bone gaps which were there were filled with the bone graft, which you can see here. There was a almost gap between the medial and the lateral condyle. And this is after almost 9 months. The fracture has very well remodeled. Patient has achieved almost 90 degree of ROM, and he is able to do his all routine activities. So this is another case of an 80-year-old female with a varus knee, came to us with the knee pain and leg pain. The X-ray showed 2 stress fractures at upper third and lower third, and we advised her a knee replacement, but she was, of course, having her issues that you can manage it conservatively. But after some time, she had a trivial fall. The upper stress fracture gave away. So options here were either to do a knee replacement, either to simply do an interlocking nail and leave her with the knee pain, or either do a knee replacement with a locking plate or a tibial extension rod, and of course a locking plate for the distal fracture, the distal stress one. But all the last 2 had a chance of soft tissue damage. So we went ahead with a tibia nailing, which bypassed both the fractures, and in the same sitting we did a knee replacement. So this is patient at almost 3 months. She was walking comfortably and had a good knee range of movement. And of course, it was a very cheaper option. The tibia nail is very cheap compared to the long extension rod. So this is at 3 months. 3 years later, she came to us with an intertrochanter fracture. We did a PFN in her, and look at the remodeling which is there in the tibial fracture. So again, she's back to her Now she's in walking comfortably, but this is the post-op image, the post-op video. So this is another case of a 70-year-old female. She got her HTO done and a PFO done 20 years back somewhere. Came to us with knee pain and all sorts of complaint. Femur is routine here, but tibia you can see there is a challenge. There is a patella baha and there is a high posterior tibial slope of around 35 degree. To balance the gap, it was a challenge. So we did a PS knee. Patella eversion was managed by proximally extending the incision. Tibial slope was reversed by 25 degree, so that the stem goes into the shaft. And to manage the tight flexion gap, we did a 5 degree of ER cut, chamfer cuts. So here she is at 15 months. She walks comfortably and has an 90 degree of ROM. So this is a typical case of 65-year-old female who came to us with knee pain, and she was walking with this fracture, and she was having this pain for 10 years and painful gait since 3 weeks. So it is a typical stress fracture. In this case also we did a knee replacement with an extension rod. This is her at 3 months. The right knee still has varus. The left is now fine and she is able to walk properly. So another bilateral OA knee with gross genu varus. The left side, it was a stress fracture. So we did a knee replacement with extension rod, and of course some screw augmentation was done here. After 4 days, we went ahead with the second knee. This is at 3 months. The fracture is almost healing. The alignment has been corrected. And this is her at 3 months, almost 120 degree ROM, and the alignment is now proper, and the fracture is healed, and she is walking comfortably. So another case of a gross stress fracture and knee osteoarthritis with genu varus. You can see fracture was attempting to heal, but it was a fixed deformity almost at the fracture site. So in this case, we had to manually break the fracture after spinal anesthesia, and then we also put a slab here for almost 3 weeks. So in other knee, it was tibia nailing was done somewhere, and this is at 1 month. This is at 3 months. You can see the alignment in the left side is almost corrected, is totally corrected, and right knee still varus is there, and has a respectable ROM. This is the last case of a 65-year-old female. She was also having this stress fracture, was was bearing this for a long time. Again, in this also we did a long stem total knee replacement. And this is her at 5 months. The fracture was almost united. You can see posterior callus. This is the range of movement. She is able to squat and cross-leg sit. Even if we deny the patient is comfortable, she does all those things. So we have to think beyond. We have to analyze before we proceed. Listen to the complaints of patient. Thorough history taking should be done. Look at the joint above and below the fracture. If there was any trauma, what was the cause? Whether the alignment is deranged or what. Treat the cause. If possible, try to give maximum satisfaction to the patient by doing a single surgery to relieve all the problems. Thank you.
Thank you, Dr. Aayush, for nice presentation. Fracture in TKR in tibial fracture. Now, next speaker is Dr. Sudeep. His topic is ankylosing